Amyloidosis. Pathophysiology. A variety of very different processes lead to the extracellular deposition of fibrillar protein aggregates that interfere with tissue structure and function. All amyloid proteins share a similar core structure of beta sheets with strands perpendicular to the long axis. The precursor proteins may derive from serum amyloid. A. Reactive systemic amyloidosis, AA, monoclonal light chains, systemic amyloidosis associated with lymphoid dyscrasias, AL, or inherited abnormalities of amyloidogenic proteins, transthyretin, apolipoprotein A1, and the fibrinogen alpha chain. Glycosaminoglycans are deposited on top of these proteins. The process is very dynamic and cumulative, but it can be affected by reducing the relevant building blocks. The process may involve the deposition of amyloid systemically throughout the body, systemic AL and systemic AA amyloidosis, or focal deposition, cerebral deposition in Alzheimer's disease. Epidemiology. Systemic AL amyloidosis occurs in up to 10% of patients with myeloma. The majority of people with AL amyloidosis will have no apparent lymphoproliferative disorder at diagnosis. Between 5 and 10% of patients with rheumatoid arthritis develop systemic AA amyloidosis. Hereditary forms of systemic amyloidosis are autosomal dominant, e.g. familial amyloid polyneuropathy due to abnormal transthyretin. Amyloidosis occurs in 2% of patients on the European dialysis program. Clinical presentation. Systemic AA amyloidosis. A high level of serum A, a high-density lipoprotein derived from hepatocytes, is required for sustained periods to produce this disease. This may be associated with chronic inflammatory disorders, chronic microbial infections or malignancy. The commonest presentation is with proteinuria, with or without nephrosis and uremia. Visceromegaly is common, liver, spleen and kidneys. Cardiac and gut involvement are less common. Patients in 50% of cases die due to renal failure, if not supported by dialysis. Systemic AL amyloidosis. This is caused by deposition of fragments of the variable region of light chains present in monoclonal proteins associated with myeloma, lymphoma, etc. The most common clinical features at diagnosis include nephrotic syndrome, in about 1/3 of patients, congestive cardiomyopathy, restrictive in nature, peripheral neuropathy, usually sensory and symmetrical, autonomic neuropathy and hepatomegaly. Any organ may be affected except the brain. Occasionally, AL amyloidosis may also be localized. Hereditary amyloidosis. There are a variety of different types of inherited protein abnormality that produce amyloidogenic proteins. These are exceptionally rare. Dialysis-related amyloid. This is associated with the excess deposition of beta-2 microglobulin, leading to amyloid formation. Investigations. Histology. The red and green birefringence under polarized light following staining with Congo red remains the standard for diagnosis. This can be performed on fine needle aspiration samples from fat or on rectal biopsies. These give a positive yield in up to 80% of cases, which should then be followed by immunohistochemical staining for the specific amyloid type. This can also be performed on the bone marrow trephine biopsy that is usually performed to exclude an underlying lymphoproliferative disorder. Serum amyloid P. This is a normal plasma protein. Radio-labeled serum amyloid P, SAP, scans can now be performed to assess the extent of the disease, and this is 100% sensitive in cases of systemic AA amyloidosis, Fig 34. It forms a baseline against which treatment can be measured. Echocardiogram. Echocardiography and ECG to assess cardiac function. Biochemistry. Check renal and liver function. Immunoglobulins. Monoclonal immunoglobulins or Bence-Jones proteins are found in AL amyloid. Some patients with systemic AL amyloidosis will have no apparent monoclonal band in serum or urine and no excess of plasma cells in the marrow. However, monoclonality can be confirmed by looking at immunoglobulin gene rearrangements at the DNA level. Factor IX and factor X can sometimes be low in association with amyloidosis. Management. This can be divided into supportive measures and those which reduce the supply of amyloid protein. Supportive measures include those associated with the renal, cardiac, or gastrointestinal involvement. Patients with amyloidosis frequently experience bleeding problems due to multiple pathologies, the most common of which is a vasculopathy due to the deposition of amyloid in blood vessels. This should be remembered, as patients may bleed extensively following biopsies or surgical procedures. Systemic AA amyloidosis. Suppression of inflammation or chronic infection is paramount. Oral chlorambucil may improve survival possibilities and SAP scans. The serum A protein can also be measured as a response parameter. Systemic AL amyloidosis. Melphalan and prednisolone will improve amyloid deposition and SAP scans in up to 50% of patients. The responses can take over 12 months. High-dose therapy with vincristine and adriamycin, doxorubicin hydrochloride, plus dexamethasone can produce higher responses, even after 2 cycles. However, the myelotoxicity and potential cardiotoxicity of such regimens have to be very carefully followed in these patients. Autologous bone marrow transplantation is an option for fitter, younger individuals. Cardiac transplantation is also an option. Thalidomide has been shown to have some efficacy, but side effects are common. Familial amyloid polyneuropathy. Hepatic transplantation can remove the source of the transthyretin protein.